sticking around. It's a beautiful day outside. We're going to get you through these next two talks. Very interesting talks because it helps you to sort of understand your place, and this is the way that I do my job, is look for clinical trials and options for patients. Obviously, when no standard exists, the clinical trials picture becomes the one that you need to look for, and then when you've exhausted standard options, clinical trials are the ones that help you move forward and find therapy. So what's the clinical trial and what's involved in it? It's anything that tries to find the efficacy of a treatment, whether it's a drug, an injection, an infusion, meditation, swimming. We try to control for everything else to try to figure out the amount of contribution of benefit from one thing. It can be anything. When we talk about it, we talk about different phases of clinical trials. Someone says, I'm going to put you on a phase 1 trial, or a phase 2 trial, or a phase 3 trial, or a phase 4. There's 4. You really need to know what they're telling you about. So phase 1 trial is for all comers. That's almost exactly where most ocular melanoma trials come. Phase 1 trials take a drug that's out there that's new and are looking for the appropriate dose and an understanding of the toxicity, where efficacy, which means the benefit, is a secondary endpoint. It's not the main thing they're looking for. So they start at lower doses and they allow everyone to understand what's going on. We have a drug X. It's going to start at a tenth of the most toxic dose that we found, and we'll go from there. We'll accrue 3 people, and then if it's not toxic in humans, we'll go to the next dose, which is a quarter, and then we'll go higher and higher and higher. Once you find the dose that is the most tolerable dose, then you go on to a phase 2 trial. Phase 2 trials pick a type: colon cancer, lung cancer, breast cancer, patients with Alzheimer's disease, patients with rheumatoid arthritis, only one type, and take the approved dose and then look for efficacy. Let's see if it works in 10% of patients. Let's see if it works in 20% of patients. Let's see if it works in X% of patients. And then once you find that efficacy, you either decide that you want to take that drug forward and get it approved, or you bail on the drug or the therapy or whatever. At this time in the United States, for drugs that are for tumors or diagnoses that are orphan diagnoses, that don't have a standard, that are not at a high enough incidence to do large trials, the FDA has agreed to approve trials for these tumors based on phase 2 trials. Drugs get approved on that. That's how some of this IMC-GP100 bispecific is going to get approved. Small phase 2 trial in patients with ocular melanoma. This is how drugs in basal cell carcinoma, or drugs in rare adenoid, glandular tumors have been approved. For higher incidence tumors, the phase 2 drug data gets looked at by the pharmaceutical company. They call in people like me to say, is it worthwhile? And then it goes up in a match. A phase 3 trial is a randomized trial looking at that drug versus the standard. If the standard doesn't exist, it's versus whatever your oncologist gives you. And that is a head-to-head, treating X number of patients in each arm and seeing which one is better. When a phase 3 trial is positive, the new drug shows benefit, then the FDA has to approve that drug. Phase 4 trials are done after approval to understand toxicity, to understand some further data that hasn't been gotten before. And usually patients like mine don't go into phase 4 trial. What is the drug? That is something you need to look at. Does it make sense? If I am opening a trial with a drug that targets some mutation, But the phase 1 trial takes everyone, even patients who don't have the mutation. Does it really make sense for a patient to go into that trial? If you've gotten treated with chemotherapy 3 or 4 times, is it worthwhile to go through chemotherapy again? And that's the decision you need to make based on your options. Is there a device? Is this a device trial? Now that's sort of like how they'll probably take the oil, those of you who are here for the oil therapy and radiation, and show it's better. It doesn't have to be for metastatic disease. It could be, is an initial surgery better than another? Like the Delcath study, is it better than a different type of liver ablation? And is there a placebo? Most trials, and there is no placebo ever in a phase 1 or a phase 2, it's only one arm. In phase 3s where you're comparing, there may be placebo. And that's a risk that you take if there are no other options available. But mostly now, as we have other options available, less placebo trials. Am I eligible? So some patients come to see me and they say, I was just sent here to see you for this, and I say, well, I don't think you're eligible. Your doctor would have called me and told me that you have rheumatoid arthritis. I'd tell you you're not eligible for this trial. You may be eligible for another one. What is the inclusion and exclusion? Male, female, age, organ function, etc. Those are things that you decide with your physician. And when in therapy is it worthwhile to go and get these treatments? Is it when you're first diagnosed? Because there are trials that take a standard and add something to it. And that's what I would usually look for my patients, even in the first line. Even in tumors that have a standard first line, we're looking to improve. So at the initial diagnosis of a tumor, even in the adjuvant setting where there is no evidence of tumor, you want to decrease your risk of recurrence, a clinical trial would be appropriate. In the metastatic setting where there's disease in other areas of the body, even when there is a standard, the question about, is there something that could give me standard plus, or that is interesting enough that I can put off standard? Is there a possibility of that? Second line, I've tried what's standard. The second thing I'm going to try. But for me, for our patients, we push the understanding that the discussion should begin early so that there are options at any time for you. We talked about the adjuvant setting. That is the setting where you have your tumor taken out. There's no evidence of anything elsewhere, but you want to decrease the risk of recurrence. And for ocular melanoma, that's been a holy grail. There has really been no drug that is promising in the metastatic setting for us to bring it into the adjuvant. That's how it clearly works. And no drug with toxicities that are so low that you're willing to risk your patients. And those are now coming. And then what can you do during therapy? And this was a major push now when we sit down at Angeles and we talk to our pharmaceutical partners, and they say, we'd like to bring this trial in for your patients. I say, can you make it so that my patients who are doing well on their standard therapy, or even before they can screen and see if they're eligible, so that if the treatment that they're on right now doesn't work, can they get onto something else right away instead of having to screen for 3 weeks or 4 weeks and lose that valuable time? So, while I understand that most of the patients here don't have metastatic disease and are coming here to increase their understanding about this mechanism, it is important to say, how much information is enough information for me to have at this point to be able to make appropriate decisions for treatment? Should I need it, or should I need another treatment? That goes towards understanding your tumor, whether it's through the genomics of it, the risk stratification of it. We talked about ocular melanoma and PRAME mutations and BAP1 mutations, and knowing that, or GNAQ mutations, knowing that, and being able to then say, because I know this, there is a drug out there that I would seek in the first line, or if I needed, or if there was a local or a distant recurrence. Obviously, one of the major decisions and discussions that we have is, Who pays? How do I get to Memorial, or MD Anderson, or Angeles, or Stanford? Does my insurance allow me to do that? And you'd be surprised. There are some insurances that don't. There could be the trial of the century. You can't get through the door. It's impossible. And nothing has reminded me that more of someone who reached out to me on Twitter and said, be aware of this person who's coming to see you next week. And they sent me to a GoFundMe page where the patient could not get their insurance to allow them to come for a second opinion or for an evaluation of therapy, even though they didn't have any treatment available through the system that this person was on. So it's almost imperative to understand where you are, and while you're healthy, manage to move things around. Get yourself out of that plan that is restrictive. Understand how you do that. Make sure you don't sign away your Medicare to a plan that doesn't allow that for you. Most clinical trials cover all of the clinical trial costs, the extra biopsies, the extra blood draws, and some of the visits that are not standard visits. But standard of care is always the burden of the patient. That is what you pay for a normal blood count, or electrolyte panel, or a normal visit that you would have once every 2 to 3 weeks. Most clinical trials, as mandated by Medicare, don't cover those costs that you need to see. So, do you cover standard of care? Probably not. There are some that do. How about travel? You live in Tarzana and I'm all the way up in Los Angeles, and that's a 2-hour drive, or you live in, I have people who come from Fresno. If you're looking to be on one of these therapies, the majority have negotiated overnight stays. I think I got a sheet that says they'll reimburse me 18 cents per gallon to drive down here. And the same for the clinical trials, they'll reimburse you your gas, some of that. So the reason I say that is I know that your health is the most important thing, and I tell you, I've had people who come for trials who fly in from Italy to just get therapy. But it's always important to clarify that, you know, decreasing stress is also decreasing financial stress, so we can help you with that. If you have a problem and you need to pay out of pocket for a visit, an initial visit, physicians always have a mechanism to help you. We have a mechanism at our clinic that we've agreed. Interestingly, before we were affiliated with Cedars, the mechanism was that we waived the fees, and that mechanism almost got us out of business and broke. But there are mechanisms where you can give a hardship or some type of assistance. And just like the standard of care drugs, if you're getting Herceptin or Tarceva, there are foundations that help you bear the brunt of your copay. There are foundations that can help you bear the brunt, or who can be advocates for you. Melanoma Research Foundation, Melanoma Research Alliance, AIM at Melanoma, A Cure Insight, Cure OM, all of these can help you find the right places and can also help you make the decisions and help you navigate through. There are people whose value comes from being there for you. So please remember that. So where can I find these trials? Well, you can always go to clinicaltrials.gov. It is a very easy website to get to and to find trials. It's then hard to manipulate and figure out the right one for you. And we're happy to do that. And who are those people? I'm happy to do that. Tony Rivas is happy to do that at UCLA. Bartosz Chmosky at UCLA. Those of you who are in San Diego, Greg Daniels, Katie Boland, who's at Scripps, is willing to do that for you. Up and down the union, there's Sunil Reddy, who's at Stanford, can do that for you. Tara McCannell can do that for you. At Doheny, at Jill Stein. I was at Doheny, there's a lovely guy named Lynn Murphy and John Kim, I believe, that are there that can help you. It's always easier to tell your doctor, you're responsible for me. You pick up the phone, and there's no way you can't get an appointment with me, that's for sure. But there's difficulties, and you can ask your doctor to pick up the phone and make a doctor-to-doctor call. That's the least that they can do. There are physicians nationally and internationally, and as I told you before, much better and much more experienced than the person who's talking to you now. Sapna Patel, MD Anderson, Alex Shishtari Memorial, Jason Luke, who's at UPMC. All of these people have spent time writing ocular melanoma treaties. Rich Carvajal, who's Mr. Ocular Melanoma at Columbia. We, as physicians, are a band of brothers. I sit down more often than I sit with my best friend from college with these people at national meetings. We see each other all the time and discuss your care. Please ask your doctor to do the same for you. Please discuss with X. I just told you a story about a GoFundMe page through Twitter. There are message boards that can get the word out. My wife sits on she's a lawyer, which is why I never argue with her, but there's a Law Mamas page, and apparently one of these lawyer mothers had a daughter who couldn't get in to be seen for 2 months at Emory. And then, of course, my wife came to me and said, "You are going to fix this." We got that person in less than 24 hours. So you can easily reach out. Most physicians that have a presence in the clinical trials landscape are on Twitter. You can reach out to them directly. And also email through. At the very least, there are 4 or 5 ways to get into seeing a physician. It should be that easy. This is how you get into the Angeles Clinic and Research Institute. If you're ever in the area, you're welcome to come. This type of talk plays better in the Northeast during the winter time when it's cold. But Redondo is beautiful. So with that, I will take questions or statements and look to bring up the next topic. I'll look up to bring up the next topic. This talk, I stole this talk from Mike Costa, who is at Memorial, who's another melanoma guy. I made him give this talk at our melanoma meetings. It's every February in New York, but it's just about the toxicities. Really quick, you don't need to remember anything except the fact that we are at a time where there are newer treatments that are chemotherapeutic in the way that there are a therapy that's made in a lab that is made to target your tumor and shrink your tumor or keep it from coming back. To me, that's chemotherapy. Now, traditional chemotherapy are toxic agents made to target the DNA replication in your tumors and therefore cause those cells to die off. Traditional chemotherapy targets any cell that's dividing rapidly, which tumor cells are doing, and also your hair cells and your stomach lining and your bone marrow. That's why you have the traditional toxicities that we talked about. How to take care of nausea and vomiting, how to take care of hair loss, how to take care of low platelet counts and bleeding, low white blood cell counts and infection, anemia and shortness of breath. What we have done is we have pushed those therapies to the back and brought newer therapies to the fore. They don't quite have the hair loss and the marrow suppression, etc. They have other toxicities. The idea of giving a talk like this to patients is to say, it may be better to not have those risks, because those risks put you in an emergency room with a fever, put you in the hospital in a bed for a week where you lose muscle mass and you lose weight because you're not exercising, the food tastes like dog food, and you're not interacting with animals. So the quality of your life is not worth the treatment. And never has it been clearer to me than a guy who I took care of, and he was a Mason, and he continued to work. He had metastatic prostate cancer, and I told him, the next therapy for you is chemotherapy. And he said, I will not do it. And I said, come on, it's once every 3 weeks. And he said, no, it's not once every 3 weeks. I have to come one day to get blood tests and get treated. I have to come the next day and get something to keep my bone marrow up. I have to come once a week to make sure that I'm not at risk of bleeding, or I don't need transfusions. That right there, my friend, is 4 out of 21 days. If I am sick from the therapy, in a couple of days I'm going to be up in bed, there's 6 days in bed. And if I have something that takes me to an ER7, and if I need to stay, 10. So half of my quality time is going to be spent dealing with treatment. And so now that is so different. And that's the major point of this talk. When patients come to see me, I never leave the initial portion without saying what the end will bring you. The end of this talk is the hope of therapies that are clearly tailored to using your own body and the own tumor cells to get a benefit with the least amount of toxicity. And this is a tumor agnostic talk. It is. Because people say, well, you're going to give an ocular melanoma talk. Shoot, I gave this talk at a lung cancer thing. Easy peasy. I gave this at a cutaneous talk. Just erase ocular and say anything. And how do you do it? You find targeted therapies. And how do you do that? You find mutations that exist in tumors, all tumors, that may exist in a certain percentage of patients with ocular melanoma. And you use those, but understand the toxicities. Now, these are cutaneous melanoma talks, but the BRAF mutation exists in cutaneous, but not in ocular melanoma. But the NRAS mutation can be blocked through MEK inhibitors. Same thing. We know that there are adverse events that lead to dose reduction and dose discontinuation. And we know that now these toxicities begin early, so we can understand how to benefit you, when to get the right therapies, and when to stop. We've now understood dose modifications. The fact that the dosage of chemotherapy was given based on your weight and your height is not the way that we dose these things. We dose them based on a target to your cells dose. So if you weigh 60 pounds, or if you weigh 260 pounds, you're still taking the same dose. You have the same incidence of toxicities, but we know how to decrease or hold or to manipulate those dosages so that you get maximum benefit. And we sometimes hold treatment. We restart with lower dose and we target some of those side effects. If you have skin inflammation, we give steroids. With these therapies, we can have intermittent therapy. Once the IV goes into your arm and you receive the chemotherapy, there's no stopping until it goes out of your body in a week. These drugs, the half-life is 12 hours to 24 hours. If they're causing a problem, stopping 1 or 2 doses will get you back to a baseline. And that's the understanding. Dose reductions are available with this based on pharmacokinetic, where we've given these drugs and looked at what happens in the blood. So the dose levels are more scientific than just saying, this person had a toxicity, just decrease it 25%. That's what we used to do with chemotherapy. Now, immunotherapy is another way of having a chemotherapy that uses your own body against your tumor. What's so interesting is this is just like that parable of not giving someone fish as a meal, but teaching them to fish. This is not targeting the tumor directly. It's allowing your immune system to be unleashed to target tumor. And once you're treated, there are patients whose immune systems become so stimulated that they do not need further therapy. So there are times where I hold patients for treatment because they've had side effects, and we go back and look, tumors shrunk, and they've never needed any other dosing in the future. Now, what does this do? This stimulates your immune system. And I say to patients, it's like a cancer cell is an escaped convict. It's a normal person, but it's become bad in one way. And it's left where it should be, and it's going elsewhere in your body and causing problems. The immune system is like that bloodhound that they send to find that escaped convict and attack it. Like Shawshank. Who's seen Shawshank? It's like in the past. And what you do by stimulating it is just you make that bloodhound more aggressive. Your immune system shows a piece of the tumor just like the policeman would show a piece of the escaped con's clothing to pick up a scent, and your T cells go and attack. That's how immunotherapy works. Sometimes, when the dog is looking for the escaped convict, it may bite the little old lady that's crossing the street and have no problem. Sometimes when your immune system is activated, it attacks normal tissue. And there are multiple reasons for that. But what we can say is that you can have inflammation in the brain, which is like a cerebritis, headache, meningitis. Most commonly, inflammation in the skin, inflammation in the colon, which causes a diarrhea-type syndrome, inflammation in your thyroid, which causes fatigue, weakness, loss of appetite. It's important to understand these in order to be able to treat them and allow patients to continue to receive therapy. This is the same talk I give to doctors, same talk I give to internal medicine physicians, same talk I give to everyone. And we know how to monitor these. Monitor the liver enzymes, monitor the kidney function. Take a look at the skin, ask if they're itching. Do you have diarrhea? Has it changed? Shortness of breath or cough? Fatigue? High blood sugars, urinating a lot? Headache, vision changes, etc. And they're all can be treated by giving intermittent steroids or dosing of steroids and stopping the drug. What does it look like? Here's the rash. You can get the rash from targeted therapies, etc. Sometimes the rash is the fact that the immune system is targeting the melanin-producing cells in your body, and it will target the melanin-producing cells in your skin, and you'll get vitiligo, loss of pigment. And that's been associated with a good response. Patients who get vitiligo do better. Vitiligo. Okay? This is like Michael Jackson vitiligo. You can get inflammation in your mouth, on the tongue, in your mucosa, and those cause sensitivity and lack of desire to eat. These are all treated with steroids, antifungal lozenges, treatment for diarrhea and colitis. Through the understanding about who gets diarrhea and colitis, we also come to look at the stool in patients and have understood that there are patients with certain kinds of stool that get colitis. There are certain patients who have specific bacteria in their stool that portends a good response to therapy. So we've started trials where we manipulate the bacteria in your stool in order to have a better outcome from immunotherapy. So poop is important. Headache and fatigue, you don't see it here, but this person's pituitary, so at baseline is small. That's what that gland should be. It should be this big. But with immunotherapy and inflammation, it becomes that big. It can cause vision changes. It ultimately causes a pituitary gland that fails, and your hormones, like your thyroid hormones, your sex hormones that lead to testosterone, etc., go down, and your adrenal hormones that give you the pep, the adrenaline, they go down. So patients can begin to feel like confusion, fevers, lack of appetite that mimics a progression of disease, but it can easily be fixed by giving cortisol, thyroid medications, just like someone who has a bad thyroid, and testosterone injections. Often they can get inflammation, which is hyperthyroid, and then thyroid dysfunction. And so the great part about this is that targeted and immune therapies, there is a holy grail on how to take care of these toxicities. They are not toxicities that you just ride out, which traditional chemotherapy had. Yeah. My platelets are low. You're just going to have to ride it out. At 10 days, they'll start coming back up again. I'm just going to have to transfuse you. You're just going to, I'm anemic. Well, I'm just going to transfuse you, but there's no way to, fix that. These have ways that we can go forward and fix them. There are important publications, including NCCN that you heard a lot about, telling us how to work and how to prevent these toxicities and prevent them from being morbid. When you have a toxicity, we've also learned that giving steroids doesn't hurt immunotherapy benefit. Trust me when I tell you these graphs show that you continue to do well even if you start steroids. And now we're trying to understand if you have autoimmune disease to begin with, can we continue to treat you? Can we screen patients to find out better ways to treat them? And to understand who's going to get what toxicity and benefit. We're part of a clinical trial with Dr. Ganji and our endocrinologist looking at blood to identify those patients who are going to have thyroid problems so that we can prevent them from happening and prevent long-term complications. When is it safe? Even if you have a side effect significant with this therapy, the majority of patients we can restart and get them benefit. And this says that. We've shown that patients who discontinue therapy for toxicity can restart and can continue to have improvement, and we can manage their toxicity, they can continue to have benefit. We've shown that if you stop a person for something, and their disease is controlled, and then ultimately comes back, you can restart the drug and have benefit. And those are things that we had yet to see with traditional chemotherapy. What this talk is really meant to do is to tell you that in the past, we just had this traditional chemotherapy. And now we have targeted therapy, immunotherapy, and traditional chemotherapies. And you'll be surprised that we've seen patients who have failed chemotherapy come onto an immunotherapeutic and then go back to chemotherapy and have a reinvigoration of their body to respond to chemotherapy. Or that we've shown that combining two of these three together can give you greater benefit than just having one of them alone. And I think this is where we're going with ocular melanoma thing also. Not just immunotherapy, not just targeted therapy, but combining them together. Along with some of those regional therapeutics that you saw Dr. Ganji talk about. The PHP, the intrahepatic infusion of chemotherapy or radiation, or even intrahepatic infusion of immunotherapy, along with systemic therapies. And those, where in the past, if you said, I'm going to add chemo 1 to chemo 2 to chemo 3, we just say you're stacking toxicities. We found that at times it may keep toxicity stable, no increased incidence, or even decreased toxicities through different mechanisms. So I find it's the best talk to end on because it's a talk of a lot of hope and a big future in not just ocular melanoma, because this talk is not an ocular melanoma talk, it's just any solid tumor talk. But not just hope, but the idea of how we're moving forward. What My Monday is about. It's about finding the next therapy, getting our patients through clinical trials to find the next answer. And then when you have one in hand, trying to bring them together in a way that not only improves the outcome, that we put up a scan next to each other, go, this thing is shrinking. And the nurse practitioner says, oh, but the patient's in the room vomiting. You have to say, this thing is shrinking, and the patient's quality of life remains just as good or better. So with that, I'll take questions, and thank you for your time. Alrighty.
I have a question about clinical trials where they pay you to participate. What's your feeling on that?
Yeah, those are sort of like, I've come across those only in healthy volunteer trials, where you undertake a risk that you wouldn't need to take. Like, I don't need to be treated with this pill that's really not going to help me in any way, except they want to know how sick it makes me. So really, those really don't exist in the oncology field.
Unless you want your 18 cents a gallon. It's not working too good in California.
That's pretty good, right now.
Or is it a mile?
It's a mile. It's 18 cents a
It's
mile.
still not good enough.
Not good enough. Okay. You had something.
Yeah, you had said that there hasn't yet been much by the way of adjuvant treatments that were low in toxicity.
For ocular melanoma, there's no standard adjuvant therapy. Some have looked at some of the checkpoint inhibitors in the adjuvant setting. They really haven't sparked a lot of clear benefit because they, as a single agent, are not the greatest in the metastatic setting. Intrahepatic infusion or perfusion of the liver is where most people are looking. And there's some early Chinese data about that. Nothing that you can hang a hat on. If a patient came to me and said, look, I have a very high risk of recurrence. Do you think I should be infusing my liver? And I would say there's no data to show that that's beneficial. So what do you think I should be doing? And I would say, I think you should be working on understanding your initial tumor, surveillance, and then putting a team together if you need it. So at this point, there really is not an appropriate adjuvant. So the recommendation for me is, let's look for clinical trials. Let's look and see what's open. Let's go to clinicaltrials.gov and see if you'd like to go see Bill Harbour, who's in Miami, or Sapna Patel, who's in Memorial, or X, Y, and Z. And that's why I am so against physicians who then just say, well, there's like a very small study, 15 patients that was done in Yugoslavia. That's interesting, and let's do that too. Because there's no clear data behind it. There's no understanding behind it.
Can you speak at all to the Mutations trial?
Yeah, so that was done and really not positive. There's a valproic acid trial that was being done and looked at. Is it worthwhile to do a trial like that? I think in the clinical trial setting, yes. How can you monitor if there's anything in some tumors that harbor genetic mutations in the tumor? You can check circulating tumor DNA. Does that circulating tumor DNA tell you that it's going to come back or not? Data shows that it may show an increased risk of recurrence. And then you may want to monitor that, and if it starts going up, pretty much indication for an earlier look. But that's as far as I'm willing to go down on that. I tell you, let's take this tumor X, where Sutent is efficacious. There have been multiple trials looking at Sutent and sorafenib in the adjuvant setting for kidney cancer, where they were approved in the metastatic setting. And what those trials did show is that, yes, it delayed the tumor from coming back. But no, it didn't help those patients to live longer. And no, there was no better quality of life because Sutent is a bitch. The toxicities are really tough. Hoarseness, loss of enjoyment, as they call it, and fatigue, anorexia, cracking of the skin, palmar-plantar redness, erythrodystia, hair loss, hypertension, risk of clotting, those things. And that's why it's always best to do those things in a clinical trial setting. where you have an extensive understanding about the pros and cons. Okay.
I think the most important thing you said back there about 10 minutes ago was being connected with doctors like you who know the field, you know where the trials are, you know what drugs have promise, you know, particular discriminant of that person's tumor. That's the most vital information, because that way you can save time and try to get to the right therapy for you.
But that's a, you know, my number is all through this place. And an email saying, right now I am dealing with a new diagnosis, or I have a recurrence, or I need a recommendation. And those emails turn around in my inbox within 72 to 96
I saw you make an appointment in the other room right there on your iPhone. That was pretty good. That's great.
Nothing like being a physician who's not busy. Painting a shingle. All right.
Squeeze you in right here. That's good.
So I want to thank you for spending your day with me.
Thanks,
Thank
Rick.
you.